There we go. Thank you everyone for being with us on day 9 of our virtual retreat. And today is our mental health day. And I am so honored. It's kind of a dream come true for us to have this special session with amazing people from the Prechter Family Fund, which is an organization near and dear to my heart. I'll let Dr. McInnis tell you everything about that. But before I do, I'm going to have Catherine Gershmel introduce him.
Yes. Hey, everyone. I'm Catherine. For those of you that don't know me, I actually lost my sister a year and a half ago, and she struggled with mental health really since early childhood. And so this is definitely near and dear to my heart. Renee and I kind of united with this organization, and I called Dr. McInnis a few weeks ago when I knew we were going to be doing this retreat focusing on mental health awareness, and was expecting him to kind of, brush me off or give me a short, yes or no type of thing. And his interest in not only what we were doing, but wanting to know my sister from an early age and everything about her. Like the whole time I was talking with him, I had goosebumps and was just so excited to meet him and hear what this organization is doing. And I just feel like everything has kind of come together for a reason. So I know this is going to help so many people. So I'm going to turn this over to Dr. McInnis, who is the head researcher at the Heinz C. Prechter Research Center.
Thank you. Thank you, Catherine. And thank you, Renee. It is truly a pleasure and an honor to be with you here this evening, and thank you so much for the invitation. My name is Dr. Melvin McInnis, and I'm the Thomas B. and Nancy Upjohn Woodworth Professor of Bipolar Disorder and Depression. I direct the Heinz C. Prechter Bipolar Research Program here at the University of Michigan. It's a program that's been going on here at the University of Michigan and the University of Michigan Depression Center for the past 15 years. So firstly, I want to talk a little bit about what bipolar disorder is. Bipolar disorder was referred to in previous days as manic depressive disorder. The reason for that designation was that it consists of manic episodes, high energy states, and depressions, low energy states, and all of those dimensions in between. So it's not just an either or, rather it is dimensional. So a person with bipolar disorder can have days of more or less higher energy than others, or they can go really high into a manic episode and have explosive amounts of energy. On the other hand, a depression can be a little bit of a depression or a lot of depression. And so there's all kinds of grades there in between. So it's not either just one episode versus another. There are many grades of it. So when I think of bipolar disorder, I think of it as a disorder of energy. And so it's easiest just to think of bipolar disorder as something gone awry in the energy drive of the brain. When I first trained in psychiatry, the thing that amazed me the most, just could not believe it, was seeing an individual in the throes of an acute mania with so much energy, you ask yourself fundamentally, how can the human brain generate so much energy? They don't need to sleep. They can go days on end without sleeping, and they can talk so fast, and they say themselves that it's virtually impossible to follow their thoughts. It's like seeing a movie in your mind going at 10 times the normal speed. That's how fast the thoughts are going. And the individual can have such a tremendous difficult time following their thoughts. Their words will come out at random, and it's just almost like a word salad. On the opposite end is depression. Depression is a state wherein energy is gone. Energy is sucked out of the body, and in its worst situation, the individual can sort of feel that they can't do anything, that even getting out of bed is a major accomplishment. Just the energy to get themselves out of bed and get in the shower is overwhelming. So the energy can be sucked out. The individual can also experience a draining of the soul, a draining of the energy, just a draining of the feeling who they are, to the point where they feel that life can be completely worthless and not worth anything, and that they're not worth anything. And the sad and tragic consequence, often in bipolar disorder, can be suicide. dying in a condition that the individual had put themselves at risk, walking across the street or a highway without looking, or in any number of different circumstances that compromise the individual's health and safety. So why did I study bipolar disorder? Well, many years ago, when I was graduating from medical school, there was a lot of enthusiasm, and there still is a lot of enthusiasm in genetics. So I was a part of a cohort of researchers 30 some odd years ago that was just bent, bound, and determined that we were going to find the genes for bipolar disorder. And so in the past several decades, we've been successful in finding genes, but we've not found the gene. We've not found a gene that is responsible for bipolar disorder. There are a number of genes that are contributing to bipolar disorder, and we'll talk about how these genes interact in a moment. But the opportunity to come to the University of Michigan and lead the Prechter program, the Heinz Bipolar Prechter program, was truly just one of the most amazing things and opportunities in one's lifetime. And so in looking towards finding genes many years ago, we often thought, if we only understood what happened to this individual over the course of time, if we only understood, what was it that affected the individual as they were growing up, as they were living their lives, as they were going forward into time, over time, how do those life experiences, how do those internal temperaments that the individual has, how does that affect how they are doing? How does that affect the manifestation of their illness? How does the fact that they have a tendency to drink alcohol or use drugs, how does that affect the individual, and so on? So there were a plethora of questions that we were asking. So I also had the good fortune of just a series of mentors over the years, and those of us that are in research and those of us that are in academia, we truly stand on the shoulders of giants. And so there are many people that contributed to the knowledge that I have and the work that I'm doing and the directions that we're taking. And one of my teachers and mentors over the years, Paul McHugh from Johns Hopkins, he talked about the perspectives of psychiatry and that there were many different ways of looking at an individual. And so I adopted that program, or that process in the Prechter program. And so we think about bipolar disorder from what we refer to as a pluralistic way. In other words, there can be many directions or many ways that an individual can find themselves with bipolar disorder. So firstly, there's a disease. There's a bipolar disease. If you see someone in an acute manic episode or acute, really profound depressive episode, you say to yourself, there is something physiologically different about this person. Clearly, just the amount of energy that they have or don't have has to be biologically, and there's clearly biological bases, for that. But also there are psychological differences, there are temperamental differences, there are personalities. We all have personality. We all have variants of personality. We all have different types of personality, thankfully. It really makes us human to have our personality. But some features or elements of personality, like a tendency to be overreactive or a tendency to, hold things inside, those features contribute ultimately in reaction or in alongside of the biology in the manifestation of the disorder. Likewise, we all have different cognitive or intellectual abilities. Some people just have a hard time seeing things or acknowledging things, and so the cognitive abilities they contribute to our levels of frustration or levels of a variety of different successes and patterns. And then finally, or not finally, but in addition to that, there's our life story. So what happens to an individual over the course of their lifetime? Everything that happens influences how we ultimately experience life. Divorces, marriages, births, deaths, and all these sorts of things. There's also a circadian pattern. We have some people are morning people, some people are evening people, some people get disruptions in their sleep. Some people just find it difficult to align with the regular daily schedules. Some people seem to have a pattern that aligns with the lunar cycle. We've just had some individuals share with us those patterns. There are all kinds of various different patterns that we see. Individuals with bipolar disorder have tendencies to use substances more than the average person. So an individual with bipolar disorder over their lifetime, 50 to 60% of those individuals will have substance abuse or a history of substance abuse. We call that, in some psychological spheres, they call it a motivated behavior. So there's a motivation to drink or a motivation to use drugs or alcohol. And talking with people with alcohol problems, they really describe that urge to drink or urge to use. And that urge can put them at risk for a variety of different things. It can compromise their mood stability. And so anyone who has any propensity towards bipolar disorder or other mood symptoms, chronic use of substances can cause all kinds of problems and can exacerbate all the problems that are there. So finally, the individuals respond differently to medications, and we really truly do not know to this day why some people respond admirably to lithium and respond to lithium in a way that says, you know what, doctor, thank you very much. That was a great medication, and now I'm feeling so much better. I can't believe it. And, things are just on track. Others say, lithium just caused all these side effects, and it's not making me better, and this and that, and so, it's just not working. So around 20 to 30% of individuals that take lithium are really successfully treated with lithium alone. There's another 30, 40, 50% of people that respond partially to lithium. And many a patient with bipolar disorder requires a variety of different medications, and their needs may change over time. So how a person responds to treatments is variable. How would people respond to family environments and psychotherapies are considerably variable as well. So in our project, we've had the privilege of engaging so many individuals, so many people in our research, and we've learned so much. We've learned about how cells behave at the laboratory level. We've learned how the brain waves are different in individuals with bipolar disorder according to various different stimuli. We've learned that there are changes in the speech patterns that can predict when someone's mood is off and so on. We're studying the genetics to identify and study the various different genes. We have a relationship and a collaboration with a pharmacology professor who's studying one of the genetic variants that we found. So we've got a wide range of projects that we are doing, but it all focuses primarily, it focuses on the individual with bipolar disorder. So it's the individual and their family with bipolar disorder that represents the heart and soul of our projects. And so we've been so fortunate to engage so many individuals with it. We've been so fortunate to engage so many individuals that have resonated with this project and said, I know why you're doing this, and I appreciate why you're doing this. I live this life, and I'm with you on it. So we're so thrilled to have so many partners nationwide in this project, and so thrilled here. I'm very thrilled to be here tonight, and hope I can answer some questions or engage in some discussions.
Thank you, Dr. McInnis. Does anyone want to start? We have Mom. Do you want to unmute and then you can ask?
How many people are currently in your study?
So in our study, we have around 1,350 individuals, and within the University of Michigan, in one of our collaborative projects, we have an additional 2,200 individuals that have been identified with bipolar disorder that are in the wings to participate in the study.
And from what I remember, this is over many years.
This is over many years. And so the project is in tremendous depth and detail. So an individual coming into our project will give us about a day and a half of their time to participate in the studies and to allow us to ask them questions and get a clear picture of the nature and the pattern of their illness. And then they participate in ongoing projects by providing us ongoing updates as to how their moods are fashioned over the course of time.
And therefore you can see the kind of medications and its effect it has on that person, and cognitive therapy and all the things that they do, therapeutically, you can evaluate that by the outcome of that person over time.
Yes, so we don't, in the primary study, we don't engage in clinical trials. So we do know how the individual is being treated. So we know the medications that they are on, and we know the types of therapies that they are receiving. And so the goal here is to look at it from a naturalistic point of view to see, okay, what is it that keeps people well? What is it that causes them to become ill? Now, in addition to that, we also have engaged in a number of different clinical trials with collaborators around the country to compare the effectiveness of various different types of medications, to look at, for example, whether lithium is effective alone and what are the genetic variants that are associated with responsiveness to lithium, for example. So we're just interested in all aspects of the disorder. We believe that really the next phase of interventions are going to be based on knowledge, on biological knowledge, of the fundamental biology of exactly how a cell is working. And so the advantage of the stem cell project is that we can get a piece of skin from the individual and we trick that cell into growing back in time, if you will. Not really back in time, but it goes into an earlier stage of development. And then we can stimulate that cell to grow into a neuron. And so then we're able to do experiments to test how those cells react to different medications or in different conditions. And so what we found is that the cells derived from people with bipolar disorder are just more reactive. The intensity of their reaction is really profound. And what we've noticed is that lithium will calm that cell so that the reaction of the cell is not as intense, the intensity of the reaction approaches that of a normal cell. So there are many different projects that are in the lab right now, as we speak, that are ongoing to really get to the heart of what is going on in that bipolar cell. And that knowledge we'll use that knowledge to base newer interventions and treatments to manage bipolar.
Thank you.
Dad?
The folks you get in your program and your project, are they self-referred? Are they referred by physicians in the community? And when that happens, I'm wondering if you find some of them to have been misdiagnosed and you do screening.
Yes, yes. Well, thank you for that question. One of the challenges that I have and many of my colleagues have is that bipolar disorder is an illness that's both overdiagnosed and underdiagnosed. And at the same time, you say, well, how can that be? Well, there are individuals that, and care providers in the community that are very attuned to bipolar, and they're at the level of the community provider. They unfortunately have a very limited amount of time to interact with their patients. And so somebody comes in and said, I just had a really bad fight with my boss or my spouse or, whatever. And the community physician will say, oh gosh, well, and rightly so, you may have bipolar disorder. And so they may put him or her on a medication to manage bipolar disorder. And then when things don't go the right direction, then often they will send them our way for a further consultation. And so we may or may not diagnose bipolar in that set of circumstances. And the opposite happens. An individual, who, for reasons we don't fully understand, has been able to, go through life in a manner that that they've found their way and they're able to manage it, and all of a sudden something happens, boom, and they're in their late 40s, early 50s, and you take a more detailed history and you realize that their pattern of their mood swings over the years is consistent with a potentially milder form of bipolar disorder, but really gotten in their way and resulted in a number of different things in their life that they regretted, either personal interactions, indiscretions, or purchases, or things like that. So there's a whole host of things that are in the wake of an individual that has been misdiagnosed, and that. So yeah, so in our study we have around. It's hard to give the percentage, but I would estimate that around 20 to 25% of the individuals ultimately aren't bipolar disorder. We also have a fairly clear-cut screening process to identify individuals that come in, to make sure that we really only bring in the individuals that we're kind of sure have it. But even then, we still identify individuals that really just have recurrent major depression, for example, and they don't have really clear-cut manias, or they had a period of time where they were using cocaine or using something else that caused them to be really revved up and appear to be manic, and that. So there are many different things that can fool us, and physical diseases. We have had individuals that have come in, and we kind of thought they had bipolar, but we kind of wondered about it, and then a couple of years later they were diagnosed with clearly diagnosed with a physical brain disease that mimicked the symptoms of bipolar disorder. So the emphasis that I want to put on it is that bipolar disorder is an illness that we diagnose over the course of time. And the fundamental successes that we have in our project are that we are looking at individuals over the course of time. And at time, as many a physicist, Einstein taught us that over 100 years ago, that time is important in conceptualizing humanity. And it's important in conceptualizing a disease. Bipolar disorder is an illness where time is a major factor. And so we learn so much by how bipolar disorder behaves, or how the illness evolves over the course of time. And that's why it's fundamentally important to follow individuals over the course of time. A one-time assessment is a good thing, but assessing an individual 2 and 3 and 4 times, knowing a person over an extended period of time, is really fundamental. So my recommendation always to individuals is to find a good treatment team and stick with them. That treatment team is going to make errors, there's going to be mistakes, there's going to be problems that emerge, but if you've got a good team that and you can stick with them, that is a really important thing, because knowledge of your illness over the course of time will help that team identify strategic ways for interventions.
Thank you.
Barbara, I saw that you had a question.
Yes, thank you. My mother had bipolar. They called it manic depressive, and she was first diagnosed probably in the 1940s, and was hospitalized a couple of times.
Mm-hmm.
She did respond well to lithium, but she responded so well that she would decide she didn't need to take it anymore.
Yeah.
And eventually she was, twice when she was hospitalized, she was given electroshock therapy, which terrified her.
Mm-hmm.
But I guess my question is about the genetics, because it turns out that my mother's family has a history of not only bipolar, she wasn't the only one with that, but there was also obsessive compulsive disorder and depression that showed up as well. And so I'm wondering if you have had the opportunity to study families and look at the genetics.
Yes, well, I began my career with the conviction that we would find a single gene in a family. And so we studied many families very carefully, and we wanted to identify families wherein the gene seemed to be coming down, if you will, one side of the family. And firstly, just to comment on your mother, I'm so delighted to know that she got lithium, early on, because it was not common in earlier days to get lithium. And I'm also glad to know that she got ECT, because ECT is one of the most effective ways of managing both the depression and the mania, in fact. And so it can be very effective in both both sets of circumstances. So, and also the story that you share about your mother, sadly, is common amongst individuals with bipolar disorder. And so the challenges that we as clinicians face is how do we convince our individuals that we're caring for to continue and endure, with the treatment. And so that's one of the strategic things that we need to get better at. So we work with a whole host of psychologists, of social workers and nurses, and others that are providing psychotherapy to individuals with bipolar disorder. And one of the fundamental things that we emphasize is, how will you know when an episode is coming on? And that, in fact, is one of the most problematic and challenging things that a family and an individual has, is how do I know it's just not a bad day or a depression coming along, or it's a good day and a manic episode coming along. So that's a major challenge. You talk about OCD and depression. So in families wherein bipolar disorder is found, many other psychiatric illnesses are often seen as well. Panic disorder, anxiety disorders, OCD, are frequently found in individuals that have bipolar disorder. And in fact, the OCD can vary in the intensity of the obsessive thinking according to the symptoms of the individual. So it's not uncommon, or it's common in an individual who has bipolar disorder and OCD, that when their depression becomes more problematic than the OCD, it's sort of turned up a notch or two. And so all of a sudden the ritualizing behavior, the hand washing or the checking or the, whatever the behavior is associated with the OCD, will become more problematic. And often that can be an indicator, a marker, if you will, that something is going wrong. And I've had a number of family members contact me about a patient that I'm treating and say, I just know something's going on because he's starting to do this behavior, and there's something, his mood seems fine, but something else is going on here, and that, so we need to take a look at it. And that goes into the importance of the longitudinal relationship with the treating team, and the importance of studying the illness over the longitudinal nature of the disease.
Dr. McInnis, it's extremely impressive what you're doing in your organization, but for people who live all over the country, can someone just go to their doctor, their primary care physician, and say, I'd like to be tested? Is there a blood test or a medical test for bipolar manic depression so they can identify it and get to at least know what's going on? Is there something that clear cut?
Well, thank you for bringing that up, actually. And unfortunately, there are no markers. There is no blood test. There is nothing that will tell you unequivocally that you have or have not got bipolar disorder. Now, there are many labs or many entities out there that are making suggestions that they can test for a variety of different things. And there's one test that may be helpful to someone, and it's a test of the metabolizing enzymes for medications. There are a number of companies out there that offer that, and they market it along the lines of finding the medication that is right for you. Now, what their tests tell you is whether you're a fast metabolizer or a slow metabolizer of psychiatric medication. So someone who is taking medication, for example, such as Risperdal, Seroquel, Zyprexa, or any of those things, they're metabolized or processed in the body by a number of different chemicals that are called enzymes that are found in the liver. And sometimes these enzymes, these metabolizers, they work faster or slower. So if you've got a system that works really fast, you need to take a lot of medication to keep up with the system. If you've got a system that works really slow, maybe you need less medications. But they don't tell you whether you're going to ultimately respond to bipolar to medications, but they give the clinician some assistance. So they're not without merit, but they don't tell you that you will respond to this medication and that you will get better from X, Y, or Z. There are a number of companies that I've read about and seen that offer imaging or sort of certain sets of imaging scans that will say, well, this is what a bipolar brain looks like. And those data can look very impressive on a computer screen or on a website. But when push comes to shove and you do larger scale studies, the error rate or the accuracy of these tests are not what they're pumped up to be. One of the reasons that we are doing the research that we're doing and getting individuals in a longitudinal study and following them over time is to be able to identify markers over the course of time that will give us a likelihood that somebody may be developing an episode. Now, one of the problems that the general public faces is that it's difficult to interpret what scientists are saying. My grandmother, bless her soul, she said, well, these scientists, they're just always saying one thing and then saying another. And she would shake her head when some contradicting study came out. But that's the nature of science, is that there is evidence of something and it's interpreted in the context of probability and likelihood. And so the average person really has a hard time with the concept of probability. If you walk across the street, there's a non-zero chance that you're going to get hit by a car. But for me, it's either 1 or 0. I'm either going to make it across the street or I'm not, and hopefully we make it across the street. But if I got a 0.0134% chance of hitting by a car, that doesn't mean very much to me as I'm walking across the street. I want to know, am I going to be hit or not? So those are the challenges in the marker world and the developing biomarkers, is that there's a certain amount of uncertainty yet in it, and we're working to clarify that. And it's very time intensive and very expensive work.
Does anyone have any questions for Dr. McInnis before we close? Dr. McInnis, I want to thank you for your time, and can you leave any last words for us and how we can help your organization and just support those that are struggling in our lives with bipolar?
Well, thank you for that. So firstly, helping individuals that are struggling with bipolar disorder, I think the first and foremost is to be there. And just the connecting with someone with bipolar disorder, just to say, hi, how's it going? And just the knowledge that somebody's reaching out to connect with them. And that is so important. And in these times of social isolation, I think it's even more important. And we're all becoming more socialized to Zoom. I think it's truly amazing. Our world would have been, or this experience would have been completely different had it been 20 years ago, or we didn't have this technology to engage with that. And I think that over on a larger scale, we are always looking for individuals who resonate with our work, and we want to find individuals that are aligning with what we're doing, that are interested in what we're doing. We're always super enthusiastic to share with people our ideas, and just look for ways to collaborate and partner. So we're always open to partnerships. We're always open to collaborations. We're always open to hearing more about people's stories. In the Prechter program, Kat Bergman has been collecting stories and collecting life experiences, and I think it's a wonderful way for people to connect and share their lived experience with bipolar disorder, and provide us with the hope and the energy that we need to soldier on.
Thank you so much. Thank you, everyone, for being with us tonight. This is something I'll personally never forget, and I will continue to do whatever I can to help you with your work. Thank you for all that you do. Lisa and Kat, we appreciate you so much. Catherine, did you want to say anything before we hop off?
Just a huge thank you. It was amazing to hear from you and everything that you're doing. So
thank you. It was my pleasure. I really applaud your efforts, and I'm just so delighted to know that you're doing this for the world effectively, and reaching out and engaging people and stimulating conversations, and that's what we need, more conversation.
but we can do that. We will soldier on. Thank you, everyone.
Thank
Have
you.
a wonderful evening.
Bye now.
Bye-bye.
Bye.